So perimenopause is the devil.
Okay, where are we at here? Okay, so understanding perimenopause. So the objective of today, it's really hard to talk about perimenopause because, like we've said before, menopause symptoms, it expands perimenopause, menopause, postmenopause, but there was such an interest in perimenopause that we thought we'd dedicate one full session to it. So the objective today is for us to gain a foundational knowledge of perimenopause, including the physiological changes, common symptoms, and some evidence-based treatments. And we hope that what you take away is a better understanding of how to manage your symptoms safely and maintain well-being through understanding and practical tools. And we've heard lots of different things, and we really want to give you evidence-based knowledge so you can make safe and effective decisions for yourself. So that's kind of the goal of today.
Oh, did we do the key takeaway? Yeah. Okay.
I think so.
There you go.
So perimenopause is a life stage. It is not a disease. It's kind of like, I think I heard Jen Gunter describe it as the middle child of menopause and puberty. It's not often talked about and kind of ignored. So sorry, I'm not a middle child. I am a firstborn, so I can't speak to that. But and I thought it was a funny description because I've heard lots of people talk about being the middle child, and so it's not talked about a lot. There's not been a lot of research done on the menopause transition or perimenopause, which is changing, but we're not there yet. So we're going to talk a lot today about the symptoms and what the effective treatment is for those symptoms based on the current research. There's going to be a lot outside of that we may not, we'll briefly touch on, but there's not enough evidence to support it at this time. So it is a transition, not a decline. We want you to see it as an opportunity for resilience, for reflection, for personal growth, and for self-care. It really is a time to come out of our cocoons. This is, I think a lot of us are coming into I've got no fucks left to give era. Yeah, I actually stood up to a doctor the other day who I never would have stood up to in a million years, and I was just like, yeah.
That's perimenopause.
I didn't get all anxious, my mouth didn't get all dry, I was just like, no, this isn't right. Anyway, I didn't do the finger wag, but I did it in my head. And we want you to see it as a call to action. So more than anything else, this is, some of us have taken our health super seriously our whole lives, and some of us it's kind of always been on the back burner for various reasons, right? And so this is a good time to think, what is my bone health going to look like? What is my heart health going to look like? What is my brain health going to look like? How can I support this type of this health to make sure that I thrive on the second part of my life? I don't want to say the other half, but as we talked about last time, we'll be about 40% of our lives in this next phase of life. So a call to action to take care of ourselves. You're gonna need this here. Yeah.
So many of you have seen this. This is my favorite video of all time. And if you haven't seen it, I hope you enjoy it as much
I think if you just hit the next button too. Oh, there.
Hey, are you okay?
Yeah, I'm okay. I'm feeling like just a bit hot. Is it hot in here?
No, I'm perfect.
Really? In that turtleneck?
I'm actually a little chilly.
Maybe I'm coming down with something.
Maybe it's perimenopause.
You think?
I don't know. Is it?
I don't know. Is it? No.
No.
I still wear a jean jacket. I still drink out of a mason jar.
But you're hot for no reason, so is it?
Is it?
Is it?
No.
Maybe?
Fuck.
Have you read this?
I don't know. I can't remember. Maybe.
You can't remember? It's a whole book. How can you not remember reading a book? Unless it's perimenopause. Is it?
No. Is it?
I mean, it can't be.
No, it can't
But
be.
is it?
Is it? I don't know. I still get acne. I have a snowboard.
It can't be.
No.
There's no way.
No, it's not.
Is it?
Hey!
Wait.
Oh, those are super cute sunglasses.
Are they?
Yeah, they are really.
Jesus! Wow, I don't even know why I did that. Sorry.
Oh, is it perimenopause?
No. Is it?
Is it perimenopause? I don't know. Do you have more underarm hair? My armpit hair got a lot thicker. Or was that on my chin?
God. Is it perimenopause?
I don't know.
Well, you should know. You're my mother.
I think it is.
It is?
Is it?
I'm the baby of the family, though.
You are?
Am I?
Oh, sweetie.
Mommy.
Have you talked to a doctor?
I can't sleep. I'm hot all the time. My moods are up and down. I burst into tears for absolutely no reason. Is it perimenopause?
No, I don't know. Is it?
What do you mean? You're my doctor. What?
Oh, it could be. There's not really much research. I mean, who really cares, right? But the one thing we do know is that it can last up to 10 years.
10 years?
Or more.
What?
Or less. I don't know what else to tell you.
I don't know. How about maybe you just tell me what's going on with my body? Anything? Is that too unreasonable a request?
Yes, it is. Definitely.
So I especially like that when she's in the doctor's office. I don't know if any of you can relate to the response she got. I don't know, is it? Honestly, I was talking to Angie before this, and I've focused in women's health. I've been a family doctor for 20 years, and I'm still learning this stuff. And it's embarrassing because I haven't, I should know this. This is what I do for a living. So luckily, I really feel like there's a movement, part and parcel. Everyone's signing up and showing up. Jen Gunter and a whole section on menopause was on Matt Galloway on CBC this morning. So I'm very hopeful that that's going to change, but it's kind of hashtag funny, not funny. So back to basics very quickly. In our reproductive years as women, this is the menstrual cycle. So we have our first day of our menstrual period. Our estrogen, our luteinizing hormone, and follicle stimulating hormones start rising up as the follicle matures, and then at ovulation, the mature follicle releases the egg, and quite soon after, the LH and FSH and the estrogen drop dramatically. The progesterone increases in that second phase of the cycle. For me, this is my fun phase of the cycle, and this is my I just want to retreat into a cave and not talk to anyone phase of the cycle, and that has a lot to do with the progesterone. And once the egg is released, the corpus luteum will kind of shrivel up just like I feel like I do before I start my period. Next up, then we get to perimenopause.
Hang on. Let me try again here.
So this is one of the reasons that hormone testing isn't super helpful, because there's such a fluctuation. As you can see in perimenopause, things really change. What's going on, Angie?
I don't know. I'm trying to go back to the full screen.
Oh, right. I'll keep talking and you keep
Yeah.
trying to figure it out. So
There.
in the early perimenopause, so there's two phases, and Angie's going to talk a bit about that. Early perimenopause between 1 and 8 years. The cycle variability is from 20 to 40 days. So in between the cycle length, between 20 days and 40 days, fluctuating. Like I said in the last, I often explain to patients, it's like the accordion of the menstrual cycle. They get wider apart, they get closer together, they get heavier, they get lighter, they're kind of all over the place. Then when you enter the late perimenopause, it's kind of 1 to 3 years. Your cycle length starts really spreading out. So the average is between 60 and 90 days in between periods. And once that happens, you're typically between 1 and 3 years of your final menstrual period. And then menopause, the 1 day menopause, and then the rest of your life with no periods. That's it.
Is it my turn now? Right. And yes, I'm still wearing a jean jacket, and yes, I have a snowboard. I don't use it as much anymore because my knees hurt. I have it, and it's exciting that I have a longboard too. I did ride down that on my street. They repainted it, and it was lovely, but I did the massive speed wobble, and I'm gonna bite it here, and everybody's gonna see it. The menopause transition. So The menopause transition is kind of the more scientific term used rather than perimenopause. Perimenopause is very vague, but they can be used interchangeably. The biggest thing to know about what is perimenopause is it includes the year after menopause, whereas the menopause transition is all the years, once you start with the hormonal chaos, up until the final menstrual period. So that's the main difference. More broadly used as perimenopause. That's what most people use, but the scientific community prefers menopause transition because it's definable. Like Lindsay said, the menstrual cycles become irregular. Like maybe you start to get a little bit lighter or a little bit heavier. Maybe you're off by a day or two. That's kind of that early perimenopause the early transition part. Basically perimenopause is hormonal chaos. That's really all it is. We talked about that a lot. That's why we get the wild fluctuations in our moods and everything, really. And again, individual experiences definitely vary. So the early menopause transition was anywhere from 1 to 8 years, generally speaking. That's a very long, vague time. And then the late transition anywhere from 1 to 3. And some women will experience their most bothersome symptoms early in their menopause transition. Some will experience it as they approach menopause, and some will have the most bothersome symptoms after menopause. So there's no way to predict how any one person is going to react. Basically, it's a crapshoot. Good luck. We're here for you. We love you. We will help you however we can. So I had a question the last time when I did the lunch session. Does the age of your first period predict when you're going to go through menopause? So if you got your first period at 9, are you going to go through it earlier? Or if you got your first period at 14, are you going to go through it later? And no, it doesn't at all, because it has to do with basically how many follicles you have and how many are released. So you could start at 9 and not go through menopause until you're 55. So the age of your onset of your first period doesn't predict your final period. What's more common is if you're a mother, you may have it close. If your mom was like, yeah, I went through menopause at 54, you might go through menopause at 54. What's even closer is if you have a sister, especially if you lived in the same environment, because you're eating generally the same food, kind of living in the same environment, exposed to the same endocrine disrupting chemicals and all those kinds of things. So
Nature, nurture.
yes, nature versus nurture, exactly. So what's more predictive is if you have a sister, an older sister, I guess, then that might give you an indication as to when your menopause might be. And always, if you smoke, try to quit smoking. It can make you go through menopause a couple years earlier, which maybe it seems like it's not a bad thing, but wait a second. Wait, maybe I should start smoking. No, Ange, no, it's not the right way to go about this. But that comes with health issues as well. Is there anything else we want to say about that one? No. I think we've kind of covered all this. Yeah, I think we can skip through that. And as we, our first day in the intro session, we kind of talked about all the different symptoms. So the most common ones, of course, irregular periods. Super common, and there are things you can do about it. Lindsay's going to talk about it, whether you're birth control pill to regulate your cycle while you go on vacation. That's a great option also if you have really irregular periods. Vasomotor symptoms, which is the correct term for your hot flashes and night sweats and everything that accompanies those, and we'll talk a lot about those. We're going to talk a lot about those because they are the most well-studied, which means they have the most robust amount of evidence to say what is safe and effective out of basically all of them. That's what has been studied. And this is why these days I think people say it's not your mother's menopause, because menopause and perimenopause is so much more than hot flashes, but that's what's been studied the most. So that's why we want to make sure we cover those as well. Mood changes, super common. Sleep challenges, obviously. Joint pain, brain fog, breast tenderness, urinary frequency or urgency. Can't jump on a trampoline more than twice or sneeze more than twice. That's personal here. Vaginal dryness and irritation and sex, pain with sex. Low energy, tired, and often you just I just don't feel like myself. Who said that? right? I don't know what's going on, but I just don't feel like myself. I call them meh. Like I just go meh, I got not a lot of joy, not a lot of energy, you know. I remember going to my doctor around 42 being like, I just feel tired all the time. She's like, well, you got lots of stress. Like, I do. So is it stress? Is it perimenopause? Or not? Is it?
Combination.
Like, is it?
Oh, this is
Sure.
you. Just briefly. So with diagnosing, again, like I mentioned, lab testing is not routinely indicated or often even helpful. What we do is based on patient, person symptoms, just like Angie was talking about, lots of the symptoms. If a woman comes in to my office talking about some of the other symptoms that are not specifically vasomotor, which is, again, what we have the most research and the biggest indication for starting therapy and counseling around treatment options, it's always important to get a good medical history, a good history of the presenting illness, focus on family history, and do a proper exam. So just because you're having that accordion menstrual period, heavy, light, long, short, we could say it's likely perimenopause, but there's lots of other questions that you should be getting asked. Should you be checking your thyroid? Should we be doing an ultrasound of your pelvis to check the lining of the endometrium, to check for fibroids, that sort of thing? So again, this is not something, oh, I have these symptoms, so that's all it is, I'm not going to worry about it. It's often important to see your primary care provider and get testing if necessary, but in terms of hormone testing, not generally recommended. We talked about the 7 to 10 years prior to the final menstrual period when the symptoms begin. This is interesting. So what we typically do, so sometimes you don't know when your last period was because you have an IUD or you had to have a hysterectomy for whatever reason. There's many reasons that you may not be able to judge by the last menstrual period. So in that case, FSH has been classically, the follicle stimulating hormone has been a good laboratory test to check, because when you have no estrogen, the FSH by the hypothalamus is just going, where are you estrogen? Where are you estrogen? So the FSH levels go way up. So if there's a reason that we don't know when the final menstrual period is and we need some clarification around the symptoms, the FSH can be helpful. And coming down the pipeline just in the last 5 to 10 years, the AMH or anti-Mullerian hormone is another test that can be done to predict menopause. So I've used it in my practice not for menopause, but actually to check ovarian reserve infertility for young women who are trying to get pregnant. But newer research is coming down the pipeline that could be helpful to help predict menopause when the story is not so clear. I think you're up again.
Yeah. Just and one quick note on testing, because I get a lot of questions about that. And you know, if you're over the age of 45 and you're having symptoms, you know, just like if a 13-year-old girl is showing signs of puberty, we don't test her hormones to make sure she's going through puberty because it's a natural, normal part of life. So if you are within certain age range and it's a normal age range for going through perimenopause or menopause, we don't necessarily need tests to confirm or deny that. What we need is treatment based on symptoms if we're looking at treatment. So vasomotor symptoms are, vasomotor is just a fancy word for anything to do with your veins, really, in your peripheral, how would you say that?
Circulation.
Circulation, there we go, thank you. There's not, well, we've done a lot of research on vasomotor symptoms. It's not well understood. So we do know that it impacts our thermostat in our brain, which is our hypothalamus. It impacts serotonin, estrogen impacts serotonin, and other neurons and stuff like that. So because of that brain and estrogen connection, it increases, like it just throws off our thermoregulatory system. It's going all haywire basically. But this is why medications like antidepressants and gabapentins will work because it also impacts the brain. There's lots of great new research coming out on how menopause and estrogen impacts the brain. Again, we're behind, but that's okay. It's coming. And Lindsay's going to talk more about the medications, but I'll just say one thing. I think that's why, like, after the big WHI study where everybody was so afraid of hormones because it was going to give everybody breast cancer all of a sudden, why doctors went to prescribing antidepressants, and that was gabapentin because that was the first line therapy at that time when we were so afraid of hormones. So, but that's because it impacts the brain. At that time, they didn't know why. They just knew it was a side effect, and it worked out well. So we've got mild, moderate, severe. Mild is just like I am right now, a little bit warm, not quite sweaty. It's, not super anxious, everything's all right, I can get on with my day. Moderate, you have a certain amount in a day, you're sweating, you're not feeling great. And severe are just like, this is impacting my life. They come on strong, they come on hard. And it's not just about sweating. So some people feel anxious before, they don't even know they're gonna have a hot flash. All of a sudden they get this overwhelming feeling of anxiety and they're not sure why. And then all of a sudden the hot flash hits and like, oh, that's why. Some people get palpitations, so heart racing. So it's not just about the hot flash and the sweating itself, it's more about how is it making you feel. And super flashers are women that just have them for a very long time after menopause, even, sadly.
Oh, this woman. Look at her hot flash.
Have you guys seen this video circulating on all the socials? We tried to get the video up, but we couldn't. So this woman is an incredible woman. She has alopecia, and so she's an advocate for alopecia. But anyway, she has this video somebody took of her, and it's obviously she's outside, it's a bit cool, and her head is just like, the steam is just coming off of her head. It's quite hilarious, and she's just rolling with it, having her drink there. That's basically, I think if we didn't have hair, that's what it would feel like on a consistent basis. You just, steam is rolling off you, and the sweats.
Oh,
what
you
causes
talked about
we
that.
did that. Yeah, we're trying to fly through this a bit. So everything is interconnected. Like we've talked about, you cannot talk about menopause as just being, a lack of estrogen. It really, like, everything is impacted by everything else. Menopause doesn't happen in a vacuum. What is my stress like? What is my sleep like? What is my support system like? All of these things impact how we experience the symptoms as well. There has been studies that have shown, and they don't know why yet, but people with lots of vasomotor symptoms or hot flashes have an increased risk of heart disease and worse bone health, so osteoporosis. They're not sure of the link yet and why that happens, but they're seeing it in research studies. So depressive symptoms, cognitive function. I mean, if you're not sleeping, I always say sleep is the foundation upon which all health is built. If you're not sleeping, it impacts everything else. We'll get into sleep in another session, so I won't
The
get
next
into too much
session.
today. That is the next
December.
one. Sleep. Yes, and cognitive function is just how we think. So the brain fog, word finding, executive functioning. My ADHD is at its all-time crazy. I can't focus on anything.
So, vasomotor symptoms, prescription therapies, we're diving right in. So we're going to talk about lifestyle stuff, and we focused a lot on lifestyle in the last talk as well, in terms of menopause, and we're going to keep talking about it and talking about exercise and sleep in other sessions. Today, we both thought it would be really important if we're talking about vasomotor symptoms to talk about some of the science and evidence behind treatment options for vasomotor symptoms. So there's two major categories, and obviously, like I mentioned earlier, it's based on the person's risk tolerance, a person's personal history and family history, and symptoms. How are you a super flasher and you can't stand it? Do you get a hot flash now and again and it doesn't really bother you? So it depends on a lot of things, but there's the Health Canada approved prescription treatments, and then there's the off-label prescription. And with the off-label prescription treatments, they're still very evidence-based. They just haven't gone through the health, or made it through the Health Canada approval process, but still good evidence behind them. So we have 4 indications for menopausal hormone therapy, which used to be called HRT, for vasomotor symptoms is number 1. Number 2 is the genitourinary syndrome of menopause. That's dry vagina, painful intercourse, itchy vaginal discharge. The 3rd indication for menopause hormone therapy is prevention of bone loss in a postmenopausal woman who's at really high risk, either with a family history or a personal history of fragility fracture, somebody who's been on steroids for long term, which increases bone loss. And then the 4th is hypoestrogenism, which is a fancy way of saying my ovaries don't produce estrogen anymore. So whether you've had surgery to remove your ovaries, or you've gone through premature ovarian insufficiency or menopause before the age of 40. The contraindications, so the big one that everybody talks about is breast cancer. Family history of breast cancer, even if it's in a first-degree relative, it's a conversation you should have with your healthcare provider, but it's not a clear contraindication. If you've had a personal history of breast cancer, you should not have estrogen, you should talk to your oncologist, and you should not have progesterone. Other contraindications, unexplained vaginal bleeding. Again, we can have abnormal bleeding leading up to menopause, but the difference is you've been investigated, like I mentioned earlier, with the appropriate investigations and have been deemed to be in perimenopause and not another reason for abnormal uterine or vaginal bleeding. Pregnancy is a contraindication, cancer of the uterus, severe active liver disease, and coronary heart disease, having had a heart attack or stroke, dementia, having a high risk of blood clots, so a personal history of a pulmonary embolism or a DVT would be a contraindication to the estrogen component of menopause hormone therapy. So systemic menopause hormone therapy has been shown to be the most effective at helping with vasomotor symptoms of menopause. It's been shown to have a 90% improvement in moderate to severe hot flashes and night sweats. It works. So I think it's really important to have that fulsome discussion before initiating and proper investigations, but it really does work if you have debilitating symptoms, and it's about risk versus benefit in terms of how things are affecting your quality of life. Hormones are available in pills, patches, sprays, gels, a vaginal ring, all kind of are things that I would prescribe. Pellets are unregulated, and I have some serious concerns about them, and also bioidenticals, which I will get into a little bit later. I think Angie will. So estrogen therapy, the 2 main are estradiol and CEE, which is conjugated equine estrogens. This is horse pee, getting your hormones from horse pee. That's been around forever. The difference between the 2, this has a bunch of different types of estrogen within it and actually carries a higher risk of blood clots. So estradiol is a safer option, and when it comes to blood clots, transdermal is safer than oral when it comes to estrogen.
Can I just say one thing, Lindsay?
Yeah.
So that WHI study, it was only Premarin, which is the CEE, the conjugated equine estrogen. That was what they were using. There wasn't transdermal, it wasn't estradiol, it was just the Premarin. And that's not to say that it's unsafe for everybody. There's great indications for it still. Lots of doctors still use it and patients still prefer it. But it was very skewed for many reasons. It was a great research study, but it was just, unfortunately interpreted incorrectly.
Now, if you have a uterus and you are interested in going on menopause hormone therapy, I cannot stress enough, and I hope you all know this already, you must have a progesterone in addition to estrogen to protect the lining of your uterus. Because if you have unopposed estrogen entering your system, you can develop hyperplasia of the lining of the uterus, which is thickening, which predisposes and increases your risk of cancer of the uterus. So it is so important that you remember estrogen and progesterone if you have a uterus. If you do not have a uterus, you can take the estrogen alone. And it's also very important to note 8 to 12 weeks to reach kind of the full effect. So if you try it for 2 weeks, 3 weeks, and you're not noticing any difference, I think it's important, if you are tolerating the side effects, to give it some time. Benefits of menopause hormone therapy, the two biggies. What we're focusing on is reducing vasomotor symptoms and helping with the genitourinary symptoms of menopause or vaginal issues. The softer indications, which they're soft because we just don't have the robust evidence, and we may in a couple of years, 5 years, 10 years, but joint pain relief, some studies, prevention of bone loss has actually really good evidence to support. And then in the perimenopause period, menopause hormone therapy has been shown to increase or improve the mood. Improve the mood. Yes, Jen?
Sorry, it's always me. But so, if the preventing of the bone loss, is that over and above what you can do? Like, would taking the MHT, would that be add another layer of bone loss density
Prevention.
issues on top
Yeah.
of your weight?
Yes.
and all
So Jen had a wonderful question. Does menopause hormone therapy act as an adjunct to lifestyle changes to support and keep your bones strong? Absolutely. So if it was separated out and people did no exercise and no strength training and no weight-bearing stuff, menopause hormone therapy alone can help preserve bone strength. What else we got? The risks. So the risks of estrogen and progesterone, or progestogen. Breast cancer, that's what everybody talks about, that's what everybody's worried about. Yes, there is a risk. The longer you're on it, the greater the risk. So every woman who is deemed low risk, no family history, no personal history of breast stuff, has a 63 in 1,000 chance of developing breast cancer at this stage of life. If you went on hormone therapy, that risk increases by 1 per 1,000 people per year. So the more years that you're on hormone therapy, the increased risk, but 1 in 1,000 per year. So I feel like the media, the Women's Health Initiative, kind of overestimated the risk of breast cancer. There certainly is a risk, but it may not be as significant as you have believed.
Yeah. No, and the Women's Health Initiative study also looked, the average age was 63. So it wasn't looking at younger women who were younger around the menopause itself. It was women who were in their 60s and 70s. So if you start menopause hormone therapy after age 60 or after 10 years of your final menstrual period, you are at increased risk for breast cancer. You are at increased risk for cardiovascular disease and stroke. But it's the opposite if you started around within 10 years of your final menstrual period and around that menopause transition. So that was
That's it. The big
it was
risks
the
were
age.
breast cancer, heart disease, stroke, and blood clots. And that has all been debunked, just like Angie said, because of the age. What was that?
I think we're activating Siri.
Oh, Siri's talking to us.
Fight with me, Siri.
So again, the increased stroke risk only happens after the age of 60. Heart attack, not heart attack only, heart attacks only increased risk after 10 years after your final menstrual period. There could be a cardioprotective role of hormones that we're not quite sure about, but more research is being done. And with blood clots, that is significant. So in the first 1 to 2 years of you taking it, you're going to have an increased risk of blood clots. That's just like being on the birth control pill. We counsel all of our patients who's taking any type of hormones for the blood clot, but it's in the first 1 to 2 years of use. So other increased risk of blood clots would be if you were a smoker, and if you were if you had a BMI over 30 or were considered obese by that standard, that would increase your risk of blood clots as well. So it would be a discussion with your healthcare provider. Like I mentioned, lots of different ways to get hormones into you. Oral estrogen and transdermal estrogen are two of the most common ways. And with the progesterone, oral progesterone in a cyclic nature from day 12 to 28 of your period, or you could get a lower dose every day, 100 milligrams once a day. IUD is a wonderful progesterone component to help protect your endometrium that has more localized therapy because it's within the uterus. It's an insertion, it's a procedure, but then you don't have to worry about it. Transdermal progesterone doesn't work in the studies. There might be a study that comes out that says it does, but right now it doesn't give enough protection for the uterus through the skin. It's either oral or through a intrauterine device, not transdermal. And then estrogen has side effects of, just like when our estrogen goes up in our cycles, nausea, breast tenderness, and headaches. And the progesterone is like bloating. It's like that second phase of the menstrual cycle, bloating, vomiting, diarrhea, mood irritability, runny nose, weird stuff like that. This is something new. Oh, yes?
What is Vagifem considered?
Oh my gosh, yes. Why is that? Vagifem is intravaginal.
Well, I
Yep.
think we were going to maybe talk about that when we did the pelvic health stuff, but that's okay.
Yeah.
We used to talk about
Do you want to talk about this one? Are you going to do it?
it. No, you go ahead.
So Vagifem, really popular. So it's an insert into the vagina, and it is estrogen. It's local estrogen, does not help very much with vasomotor symptoms. That's why this is the focus of this part of the conversation is the vasomotor symptoms. But for genitourinary symptoms of menopause, you don't need progesterone because it's local therapy in the vagina. It doesn't go systemically, so you don't have the same risks. So there's lower risk of breast cancer, lower risk of clots, lower risk of heart disease because it's local, and you don't need the progesterone piece to offset to help with the endometrial lining if you're giving that local therapy. Great question.
So if you're still taking birth control pill and it's a progesterone-based one, is it considered?
Yeah, a lot of women in perimenopause that are kind of struggling with irregular periods are on the pill, and it actually helps. I don't think it's going to really help with vasomotor symptoms, but it certainly helps regulate cycles in that period of hormone chaos, and it can be safe. That said, hormones in oral contraceptives are higher in potency than menopause hormone therapy. So again, everybody's so scared of menopause hormone therapy, but the actual estrogen and progesterone, or progestin only, components of the birth control pill are higher in potency. But that can be a kind of in-between. If you have cyclical abnormalities in your menstrual cycle, that can be a really good option, but it won't help treat vasomotor symptoms.
I guess what I'm wondering is that, like, is it, when you're in this type of hormone therapy, are you still at risk of getting pregnant then?
That's a great question. Yes, you are. Because it's lower dose. Stick with the birth control pill.
Yes.
You can still get pregnant when you're perimenopausal, everyone.
Yeah, so that's a great point. So you should be, if you are at risk of pregnancy, you should be taking birth control pill until 1 year after your final menstrual period. 1 to 2 years after your final menstrual period.
What if you're on an IUD or a continual cycle and you don't know when that happens?
Well, the IUD is...
The IUD is protective.
Yeah.
And contraceptive.
It's more like when you know when your last period is. When you
That's when
Yeah,
sometimes lab studies can be helpful, like the FSH level.
Yeah.
Yeah.
But if you're looking at treating symptoms, so I'll say this from experience. I had an IUD, so my doctor was like, "Well, when's your period?" I'm like, "I haven't had one for 15 years. Like, I don't know. I can't go by that." So she just said, "Well, you're having symptoms, so you could be anywhere on the perimenopause spectrum. Like, should I have blood work?" She says, "No, we'll just treat your symptoms. Start you on the lowest dose possible." So added the estrogen because I already had the progesterone through the IUD. So.
And that's a really good point, Angie. Lowest dose. Always start low, go slow, like with most medications. That's really important. I'm just going to briefly touch on this. This is another thing coming down the pipeline. I do not prescribe this. I'm just learning about it even through this session. It's tissue selective estrogen complex, TSEC. It's basically estrogen with a selective estrogen blocker mixed in with it. And it's called Duavive.
Duavive. Basodoxifene.
With this one, so it is a SERM with an estrogen, and a SERM is something like tamoxifen. So anybody that you may have known, or anyone with breast cancer, once they go through therapy, they're put on tamoxifen to block the estrogen receptors. So basically this medication works on feeding the bones estrogen, but not the breasts and the uterus. So I think there's a lot of promise. There's good evidence to support it. Hot flash reduction, bone health, and quality of life improvement. No increase in breast cancer and no increase in endometrial cancer.
And I think it's important too, so for people who can't tolerate progesterone or progestogens because it impacts mood or headaches or whatever else, this is an option. But you still need estrogen or want estrogen, this is an option as well to protect the uterus.
I don't know much about it though, and I don't know if there's any family doctors prescribing this. I've seen a few gynecologists on reports come back that have started. Yes, Sue?
So although there's no increase of breast cancer risk, if you've had breast cancer, are they using this?
That's
or
a
not?
good, we're gonna do the non-hormone options for medication. So Sue's question was, if you've had breast cancer, would this be an option? You would probably still be on tamoxifen or some SERM, but it doesn't, I still think it's too risky with the estrogen.
At least with the studies so far. They are doing more studies are coming out, which is great, but from a safety perspective, again, what's our risk tolerance and where are we at? You okay?
Yeah, let's keep going.
Okay, yeah.
I'm gonna quickly talk about non-hormone things, medications that I could prescribe or your primary care provider that can help with vasomotor symptoms. So, antidepressants, not because it's all in your head, but because like Angie was talking about the hypothalamus connection with serotonin, with reduction of estrogen levels, it can really actually help with vasomotor symptoms. So medication like paroxetine, which is Paxil, venlafaxine, which is Effexor, escitalopram, which is Cipralex or citalopram, which is Celexa, can all be beneficial. And then anti-seizure medications like gabapentin or Lyrica, other name is pregabalin. Originally for seizures, but actually because they modify neurotransmitters in the brain, they calm things and they actually have been shown to reduce vasomotor symptoms. So if there's a contraindication or you're not interested in hormones, there's lots of other options. Then there's the non-meds.
Yeah, lots of great therapies out there. And just a quick note on menopause hormone therapy. There's lots of great studies coming out and how it can help with mild to moderate depressive symptoms in the perimenopausal years. The evidence does not show that it will help with depression in the postmenopausal years. So if you have some mild to moderate depressive symptoms, menopause hormone therapy can help. And more severe, that in conjunction with an antidepressant can really help increase our mood. And for those of us who can't or don't want to touch medications at all, cognitive behavioral therapy is very well studied and extremely effective to help with vasomotor symptoms. It can help reduce the intensity of them because a lot of it, once we start to feel it coming on, then we start to get embarrassed and then everything gets worse and we just start to kind of spiral, and CBT can really help us kind of talk through that so they're not as bad. And it can also help with anxiety and depression as well. So it's a great option, especially for our cancer patients, women who experience cancer who can't take it, or anybody who also doesn't want to take hormones or other medications. Clinical hypnosis has been shown as well to help with vasomotor symptoms also. So there's lots of people selling lots of programs and lots of things out there to help with all of the symptoms of menopause. And there's been studies, a whole bunch of studies done on them, and the North American Menopause Society put out a position statement because they went through all of the studies done on them, and they put out a position statement on non-hormonal therapy options. Cooling techniques, so while it is beneficial to wear layers and to, you know, strip down when you're having a hot flash, the cooling technique or a fan or something like that, it's not going to stop how many you have and the duration of them. It's just going to help you feel better while it's happening. So it's not an actual therapy recommended to reduce your vasomotor symptoms. Avoiding triggers, again, you can do that because if you've got a trigger and you know something happens, like if I have a coffee or if I have 2 coffees or a glass of wine, I get all flushed and I don't want to be flushed, then I just won't have the wine. But again, it's not going to reduce the number of vasomotor symptoms that you have because of the lack of estrogen or the fluctuating estrogen. Exercise and yoga, while super beneficial, and exercise in any form, everybody should be doing. And yoga is just fantastic as well. The studies have shown that they don't reduce the severity and frequency of vasomotor symptoms or of your hot flashes. So yes, please do it, but don't expect it to cure your hot flashes. Dietary supplements and herbal remedies, lots of things to talk about there. They can be beneficial for some people if you have an iron deficiency because you're bleeding a lot, you may need to supplement with iron, or B12 deficiency or something like that. But they have things like evening primrose oil and black cohosh and other things have not been shown to reduce the severity and frequency of vasomotor symptoms for all women. If it had, Big Pharma would have clung onto it and sold it. So I always kind of think like that. So if there's like a magic cure out there, Big Pharma would definitely have their claws into it and will be marketing it at extraordinary prices for women. The pink tax, they call it. And it's not regulated. It's not a regulated industry, unfortunately. I wish it was, because I think there could be a lot of benefit to supplements. But it's unregulated. You don't know what you're getting in a lot of your supplements. And so it can be dangerous, and they're expensive. So if it's affordable to you, and it's something you want to try, and you know your risk and benefits, and it doesn't interact with any medication that you take, by all means, that's an informed decision you need to make. But if somebody's online saying they've got the magic cure that nobody has ever found that will cure all your symptoms of menopause, just run. Save your money. Acupuncture itself, in the studies, while acupuncture has shown to be beneficial, it doesn't reduce the number of vasomotor symptoms any more than placebo did. So basically, it's the therapeutic action of being, having somebody there taking care of you and getting acupuncture done that is helpful because it just makes us feel better. But when compared to placebo, acupuncture didn't actually help reduce vasomotor symptoms over the long term. So, and then chiropractic interventions did not help either. That's those ones. And bioidentical is a marketing term. Basically, it's marketed as safe and natural or matching the exact hormones of your body. Basically, other than conjugated equine estrogen, all the estradiol that is prescribed by physicians is the same raw compound as your compounding pharmacies get. It's all created in the same plant from generally soybeans or yams. So estradiol is a derivative of soy, and I think progesterone, is of yams. So it's not necessarily safer. Some people may require compounded hormones because they may be allergic to something that's in like the patch or something like that, or have allergies that's in the compounds when pharmacies make it. But basically, they're not approved by Health Canada, and there's a reason for that. Is because you don't know how much you're getting in each batch, in each dose, and they're not safer than what you can be prescribed by your physician. So. And of course, we can't. This is what I'm passionate about, because I think there's so many women that I talk to. They're just like, I just feel meh, blah. This may be a second episode.
5 minutes left.
Okay. Yeah. So, mental health, super important.
Let's just glaze over that.
It is all in your head, and by that, I don't mean derogatory. I mean literally, it's impacting. Estrogen has a huge impact on our brain. So if it's your first time feeling like this, talk to somebody, get help. use your support system. Don't be afraid of all of that. Mindfulness, resilience building, self-compassion, and CBT.
All
Where
super
we're at.
helpful.
And of course, it impacts our quality of life, it impacts our workplace, it impacts our relationships. So we need to make sure we're using our self-care tools, we're leaning on our friends and family who support us, we're getting rid of the ones who don't. And use tools like symptom tracking, because that can help then lead the conversation with your physician. This is what I was feeling, this is what I was doing. So there's lots of great symptom tracking journals and apps out there.
I went to my office yesterday, and I saw these in our physician hangout area, and it's all about menopause symptom conversation starters. What do you know about menopause? Learning about this. How do we support people in your work environment? I was so impressed. Of course, because they're nice and glossy, they are made by Big Pharma, but still, the word is getting out there. And I have to say, I've been a little bit sheepish with our medical community, that we're coming and talking all about this, and they don't really know that I'm doing that, and I'm wondering what the fallout of that might be. So Maggie and I and Sue were at a conference last week where a very giant proportion of our medical community physicians were, and I asked if I could get up and say a few words, and I'm like, so if people come and start asking for hormone therapy, I might be the one to blame, and this is why. So basically it was an opportunity to kind of tell the whole medical community, this is what we're doing. We're using evidence-based information to communicate and educate, and this could be not a fallout. It's not a fallout, it's an empowerment. But from their end, I can just see them going, oh, freaking Lindsay. Oh, this is all her fault. Anyway, it's a good thing.
It is a good thing.
Oh, and this is how to talk to your provider.
Yes, again, we'll kind of talk about it quickly, but it is important. So when we talk to our healthcare providers, unfortunately, like in today's age, our healthcare providers should know that 80% of us are first going to Google, and we're going to Dr. Google everything. I do it, Lindsay does it, we all do it, and instead of getting their backup, unfortunately, some of them do. They shouldn't, but they do. So, how do we turn that around? We really just describe how it's impacting your quality of life. Like bring on the tears if you have them. Like mine come like that. I'm not trying to be manipulative. I just mean just let it all out. Don't be. This isn't the time to be brave and suck it up and strong. Like tell your doctor, this is how it's impacting my life. What can I do about this? I can't go on like this. Summarize and track your symptoms, and say what your goal is. I'm coming in here today because I have this. I don't want to feel like this anymore. What are my options? This is what I've looked up. What can you tell me about that? And that you're, and if you're having conversations at home and at work, hopefully we have supportive people in our lives, especially our family. If we don't, then that's a different conversation. But we explain that we're going through a transitional phase right now, and hopefully it can help foster understanding. Whoever decided it was a good idea to have me going through perimenopause and my son's going through puberty was like, that was a poor planning on evolution's part. And speaking of where getting information from and Dr. Google and stuff like that, I just want to talk quickly about what's called in psychobabble language cognitive bias theory. So our brain will look for things because we like to take shortcuts, right? Like we just want, I want the quick and dirty. I used to do that on nursing report. I'm like, just give me the quick and dirty. I don't want to hear everything else. My brain can only process so much. So we will look for things to confirm what we already know to be true or what we've heard. And it's called a cognitive bias theory. There's a whole bunch of things that go underneath it. So we'll ignore information that challenges that belief. So if we've heard one person say this and we really trust them because they've got an MD behind their name, then we're not going to take anybody else's word for anything, basically. So after the next session, we've got a whole sheet on how to critically think your way through menopause information and misinformation, and that'll be attached to the final email that Maggie sends out. We didn't put it up here today because it's a lot to go through. but it'll just help you kind of, you know, the next one, Lindsay. Yeah, it'll help you work through like who's a good person to listen to. Because there's lots of physicians out there right now online who are loud voices, and there's not a lot of great evidence to support what they're saying, which
And
is
they're
unfortunate.
selling products.
And selling
That's
products.
a big red flag.
So when you're looking at like, you know, we all don't need to be scientists. There's a reason that people are researchers, and it's not me. Wait, I am now.
You are a
Wait a
researcher.
second, I am. No. But what is the best kind of evidence to look at are like, you know, randomized control trials are the gold standard. This is what you want to see. If somebody's spouting evidence that something is going to be effective, what kind of evidence are they talking about? Was it an animal trial and grown in a petri dish? Because that's not relatable. I'm not a mouse. You're not a mouse. We're not rats. So while it's effective and it's a good place to start, what we want to know is how effective has it been in humans. And unfortunately, this is where a lot of the supplement industry falls short. It's a multi-trillion-dollar industry. You can't tell me that they cannot afford to do proper trials. So that's just my little blurb on that one.
YouTube videos are not necessarily scientifically based.
And so just some quick tips on how to navigate menopause care. So what's credible versus what's a red flag. Somebody is speaking in absolutes. Every woman needs to be on hormone therapy. Everyone, right? If somebody's saying that, you're like, wait a second, that's a red flag. And so everyone, always, all the time, those kinds of terminology, if someone's using that in their marketing or just in what they're speaking, other than everybody needs to come here and listen to us, then that's somebody you shouldn't listen to. And question everybody, even us. So if they require blood work to treat your symptoms, that's another big red flag, whether that's a medical doctor or a naturopath or anybody that you're going to. If they require it to treat you, that would be a red flag. You're treating the symptoms, you're treating the person, and making sure it's safe and evidence-based. And if it sounds too good to be true, I talked about this already, it is. There is no one magic supplement that some influencer has found that nobody else knows about. This is also going to be on the sheet that we're going to give you when the last email goes out, so some good, credible sources of information. The Menopause Society, which used to be known as the North American Menopause Society, which I just got my certification to become a Menopause Society certified practitioner. Even though I can't prescribe, I can just provide education, and I love it. The Australasian Menopause Society, the International Menopause Society, the Menopause Foundation of Canada, and of course we love Dr. Jen Gunter because she tells it like it is and she follows the evidence. And we're going to provide you a personalized perimenopause toolkit. So self-care, gentle exercises, or vigorous if your body can take it, if your bones like it. Meditation,
girl
time, yeah, and of course lifestyle adjustments. So whether we always want to say whether if you're choosing medication or not. Let me back that up. When somebody asks me what is the one thing I can take to cure all of this, what is it? Menopause hormone therapy. I'm like, how's your diet? How are you sleeping? What's your exercise like? If none of that is, if you're not doing kind of even the minimum to support your own health, there is no magic pill. The estrogen therapy might help with your vasomotor symptoms, which can help you sleep, which can then help you, make adjustments to your lifestyle. But it's not actually going to cure everything. We have to make sure we're doing the foundations of health before we add a magic pill to anything. I think that's it. Menopause, the ultimate metamorphosis, where we shed the skin of our past and embrace the wings of our future.
Any questions? Thank you, guys.
Questions? Yes.
You had mentioned that your sister's situation is probably more predicted than your mother's.
Yep.
Is there any similarities in the symptoms that they have, like that you might experience too?
I believe
I think so.
Yeah, I believe so. So age and symptoms, but again, every woman's different, right? You might have spent your first 16, 18 years with your sister, but your living environment might have been different beyond that. But I believe so, but the evidence is strong for age of menopause for sure around. Yes.
That QR code takes us to the pre-test.
Oh.
Isn't it the same question?
That's my, no, don't do it again. Don't do it again.
So the question was, this QR
Actually,
code takes us to
You know what?
the...
That's okay. You can do it.
I think you
Yeah,
can only
that's-
fill it out once, Maggie. If it's the
With the-
pre-test, I thought with the Google form, you could only fill it out once.
I think you can. You should be able to fill it out more than once. As long as you use the same research ID number, I'll be able to tell if you did it before and which one you did after. So it should be fine.
So you can use the same questions because they are the same questions again. Jess?
Or
wondering, will the post-test be emailed?
yes.
Okay, it's fine.
Yeah. Post-test will be emailed. You don't have to do it right now. We're trying to catch you now because I know I wouldn't do it after I leave here. Any questions? Any other?
I was just gonna say, the link is in one of the emails that we got earlier about this.
The pre would have been sent in the email I sent last week, but when I send a follow-up email to everybody with the video and the handout next week, I will also include the post.
Yeah, I have an email
Link.
with the post in it.
That would
I'm
have
just
been,
trying to go
that
back.
might have been the previous email.
No, it said, yeah, it's
Oh.
from, not to be argumentative, but November 7th, and it says the link to, oh, never mind.
So you will be getting an email next week with a copy of the video, in case for those who missed it or want to check it out again, for the post-test questionnaire, and there's going to be some resources like the perimenopausal toolkit and a handout on menopause hormone therapy that I typically give to patients who want more information. It's so good to see such a wonderful turnout. Any other questions? Questions? Anyone want to meet at the pub after?
And then for December, I just wanted to say December, it's December 20th that we're meeting here. And the lunch session is also going to be on December 20th because next week is Christmas after that. So.
Our next, is it the 20th?
Or the 18th. Oh my God, I'm sorry guys. I can't say the time.
The next session is December 18th. It's on sleep and menopause. We have a special guest, Dr. Catherine Zakel, who has an expertise in sleep apnea, and she's going to be helping us with our presentation. Have a wonderful evening, and if you have any questions, come up and ask us afterwards. Thank you.